Um, let me just welcome you all to this Work and Health webinar, which jointly hosting across the DWP and DHSC Joint Directorate and the Society of Occupational Medicine. Thanks ever so much all for joining. I'll be chairing today. My name's Alex Fitzpatrick. I am Deputy Director for Workwell in the Joint Directorate across DWP and DHSC. It's fantastic to see you all with us today. We've got some excellent speakers, which I'll come to in a second. And just to welcome Lanre as well, who joins us from Society of Occupational Medicine. Hi, Lanre.
Hi, Alex. Glad to be here. And it's a wonderful series of webinars, and I look forward to the speakers. Apologies, I won't be able to stay the length of it, but I'm sure we're going to have a very enriching conversation.
Excellent, no problem at all. I'll keep my introduction brief so that we can get into the substance today. As Lanre said, today is the third in a series of 3 webinars, and we've had, I think, really great input across all of those. They've been really excellent conversations. So this series is in recognition of the significant investment that government is making in work and health services, and particularly in recognition of the delivery demands that's creating in local systems. You'll all be familiar with the breadth of initiatives that government is focusing on in this agenda. That goes all the way across occupational health, mental health and musculoskeletal pathways, to initiatives like Workwell and Universal Support, and most recently, of course, FitNote reform, where we've got a live a call for evidence. Within that agenda, I personally lead on Workwell specifically, and it's been a really exciting week for us as we've been able to announce publicly which local partnerships will be delivering pilot Workwell services from the autumn. Now, these webinars are, of course, intended to support the delivery of those Workwell services specifically, but I just wanted to stress up front that it's actually that we've got a much wider focus here across the whole of that work and health agenda. In setting these up, our focus has been to identify a series of questions relevant to that full work and health delivery agenda and bring together the multidisciplinary expertise that we think can help us collectively answer those questions. So in that spirit, today we've got 3 expert speakers for you across different disciplines, focused on what we're describing as work and health service essentials. So specifically, we'll be focusing on the role of prevention with help from Lola, then the role of signposting and effective referral pathways with help from Lara, and finally on working with employers with support from Louise. So Lola, Lara and Louise, thank you ever so much for joining us today, and please do introduce yourselves when you come in. One note on logistics just before we get into the presentations. So we've got until 3:30 today, and it's a full agenda, but I'll make sure that we finish to time. We'll hear from each speaker, and we'll have a short period for Q&A after each presentation, and then I hope we'll also keep some time aside for some final Q&A before we finish. Now, this is very much a conversation, so we are very keen to hear your questions. Please do share those on camera during Q&A or otherwise in the sidebar, and we can bring them together for discussion. Now, without any further delay, let me turn to our presentations, and Lola, let me turn to you first, please, on the role of prevention and understanding the needs of local areas. Thank you.
Thank you so much, Alex. Afternoon, everyone. My name's Lola Abudu, and I'm Deputy Director for Health and Wellbeing for OHID, which is Office for Health Improvement and Disparities in the Midlands. And I'm really delighted to be joining you this afternoon. So what I'm going to do is really over the next 15 minutes or so, give you an overview of prevention in the context of the workplace, and then outline how system partners can work together to really understand the work and health needs of a local area. So employment is a key determinant of health. And there's clear evidence that good work improves health and well-being across people's lives, not just from an economic standpoint, but also in terms of the quality of their life. Good work is not just about having a safe workplace, but it's also about that sense of security, autonomy, good line management, and also communications within an organization. So a happy and healthy workforce benefits workplaces, improves productivity, and has huge benefits for the economy. And for me, health and wealth are two sides of the same coin. So what is prevention and why is it important in workplaces? Prevention is about helping people to stay healthy and happy and independent for as long as possible. There are different aspects of prevention. Primary prevention, which is down at the sort of bottom of the pyramid, is really about helping people to stay healthy, to prevent problems for as long as possible. Secondary prevention, once people are at risk of health problem, it's about identifying that early and intervening to prevent the problem happening, or to try and cure it at an early stage when the intervention doesn't have to be so huge. But once people have got established conditions, really it's about helping them to have the skills, knowledge, the confidence to manage their condition well, and to maintain their independence and quality of life for as long as possible. Adults are going to spend a huge amount of their time within their workplaces, and our work has a huge impact on our well-being. But the workplace is also an important setting for health improvement. And so in terms of primary prevention, work initiatives like healthy workplace initiatives can support things like healthy eating, helping people to maintain their physical activity, managing, their mental well-being, dealing with stress and stuff and things like that. But we can also intervene early with interventions such as stopping smoking, NHS health checks or CVD prevention, which can happen very easily in the workplace. But once people have conditions, I think the workplace is enormously important in helping them to manage these issues and helping them to stay in work for as long as possible. So why is this so important? As we know, the number of people within the workplace with long-term conditions or disability is rising, and long-term sickness is becoming one of the most common reasons for people to be economically inactive. We know that this is being driven by mental health issues and musculoskeletal issues primarily, and very often it's a complex picture with people having more than one condition, whether it's a physical condition or physical and mental health conditions happening in combination. So it's really important for us to really understand what's going on within our local population and intervene to try and make a difference to this. So that brings us to the work and health, or the health and work needs assessment. Well, what is this? This is really about having a systematic approach to identifying unmet health and work needs within a population, identifying the priorities in terms of those unmet needs, and then targeting your resource to try and make a difference to this. In terms of getting started, it's really important to be clear about the population of interest, the geography that you are interested in. You need to identify your key stakeholders. Doing a needs assessment is a team sport. You need those wider stakeholders around, whether it's your local public health team, your local economic unit, employers, Chamber of Commerce, voluntary and community sector partners, community representatives. You may want to involve your education sector, such as colleges of further education or higher education institutes, and then of course job centres, DWP colleagues. So there'll be other people within your local area that may have important perspectives and information that you want to bring to this exercise. And then the next thing is gathering the information that you need around the population of interest. And this means looking at both quantitative and qualitative data. So demographic data around your population from the census, health data from resources such as the OHID fingertips tools, labour force data, trends. You also want expert opinions to inform what is happening within your local places. So once you've brought all of this information together, at this stage, it's really important to integrate all of those findings, and you will be able to identify some key issues which will be a priority for your population. And in terms of addressing these issues, you want to identify those priorities, looking at the size of the population affected, the severity of the impacts, what's the evidence about what works and what makes a difference. And, we have some of that evidence available through guidance from institutions such as NICE. And you will also have some local commissioning priorities or partnership arrangements that may inform what you decide to focus on within your local place. Having identified your priorities, identified the appropriate interventions, then there's action planning, pulling together your strategy. But an important component of this is thinking about how you're going to monitor and evaluate the impacts of the interventions that you're putting into place, and measure the effectiveness of this. And so I think, within your local place, you need to think about that early, so that you put in place the appropriate mechanisms for collecting that monitoring data, so that you can then look back and see what difference that has made. So just sort of to wind up, there are lots of resources out there that can help you in this task. I've on this slide, we've got links to some of them. The Society of Occupational Medicine undertook a very recent deep dive into trends around ill health driven fallout from the labour market. So that's useful. Your local area will have joint strategic needs assessments. And if you go on your council website, you'll be able to access this. But it's also important to think about who might be missing from the headline data. So the health equity assessment tool enables you to sort of ask the questions about the different subsets of your population that you need to take into account, whether it be because of their protected characteristics, or they suffer higher levels of inequality, and you may need to do something different to make sure that you don't further exclude them by the interventions that you're planning to put in place. And then in terms of the evidence of what is effective, Public Health England collaborated with business in the community to develop a number of toolkits and resources for employers, and that's a very useful resource to look at. And I've mentioned NICE guidelines, and these are links to some of those things. So, and a couple of examples there of people who are far ahead in terms of doing needs assessments and developing their local strategies. I think they've shared in previous sessions. Do have a look at the reports that they have produced. So that sort of brings me to the end of my slot. I've sort of given you a little bit of an overview of prevention in the context of the work setting. I've highlighted why we need to do something in terms of increasing numbers of people with disability and long-term conditions, and the economic inactivity we're seeing now, and the process for doing this, and signposting you to a number of resources which I hope will be helpful in this task. Thank you.
Thanks ever so much, Lola. Incredibly helpful, and of course it's the variation in the needs of local populations across the country which has informed the way that we've been thinking about work and health services funding, and trying to create as much flexibility as possible for local partnerships to determine exactly where funding is targeted in services like work well. So I hope everyone's taken a lot away from that presentation. We will just a question on whether we'll share the slides. I think we should absolutely do that, because there's some really useful links to resources in there. Thank you, Lola. Let me open up for Q&A, and I thought I saw a hand go up, but I don't see it anymore. So if you've taken it down again but would like to come in, do please put your hand back up. Would anybody like to ask any questions of Lola? I might just abuse the chair's privilege while others come in. So one question for me, Lola, just particularly on that section where you're talking about prevention particularly, are there any sort of particular types of preventative supports that you think would be most relevant to individuals accessing work and health assessments or work and health services, and so could be a particular focus for services like WorkWell and others?
I think not a specific one, but I think line managers actually play a really important role in all of this. And the reason I say that is that very often they will have a good oversight of what initiatives are happening within the workplace, but then also I think in very skillfully having the conversations with their reports about their needs, giving them the confidence to articulate the challenges that they might be facing, and then signposting them to what's available. And so I think it's really important that our line managers are skilled up and confident and know how to refer and signpost and have supportive conversations in a way that build confidence within the workforce.
Fantastic, thank you. I think that will link very strongly to the presentation we'll hear from Louise later on the role of employers and how we support employers to do more in this agenda. Before I move us on to our second presentation, would anybody like to ask any questions? Otherwise, do pop any thoughts in the sidebar, and we can always bring it together and discuss as part of the wider Q&A later on. Or before I move on, Matthew, do come in.
Good evening, afternoon, sorry, from Cornwall, and thank you very much. Very happy to be now. Lola, do you recognise the term health creation?
Yes, I do.
And where would that fit upon your pyramid?
So, I mean, I can't remember whose exact theory it is, but certainly we ought to be thinking about creating health. And I think that we can do that in workplaces by having the appropriate policies in place. I think making sure from the board all the way to the shop floor that people recognise the importance of well-being, and creating that environment which enables our workers to flourish, whether it's, through health and safety, considering mental health as part of our health and safety initiatives, providing whether it's occupational health, healthy, making the workplace a healthy setting in terms of the food that's available, access to physical activity, and all of those sorts of things. So I do think that a workplace can be a health creating setting by the way in which it operates and runs.
Thanks ever so much. Interesting there, and something that I'll be going away to look into myself more. So thanks, Matthew. Let's come on to Lara, who's going to talk to us about effective signposting and referral pathways. Lara, thanks ever so much.
Thanks. Good to see everybody. And yeah, this is just going to be a quick whistle-stop tour through effective signposting and referral pathways. So I'm Dr. Lara Shemtob. I work between general practice and occupational health. And in fact, it was the footnote that first got me thinking about occupational health, thinking how can I better use it in practice. So really excited to be here and start thinking about what the future might look like in that regard. As well as working clinically, I work at Imperial College London, where I help to lead a research policy lab looking at questions on work and health, and do a bit of teaching at the medical school and on MPH curricula. And at the moment, I'm spending some time in the US trying to leverage what we can from a transatlantic learning perspective. So for today, there've been some work on this embed study at Imperial College London led by Dr. Shrika Patani, and we're going to be using some learning points from that. So in that case, there have been job centre staff put into GP surgeries, and we can see a little bit about what a good referral pathway might look like, or where good learning points might come about here. So just going to have a quick look at the current landscape, think through what might be useful from an ideal pathway perspective, and wrap up at the end with some time for questions. So starting with having a think about the current landscape, where are we now? So in a situation where an individual is employed and they call in sick on day one, the first kind of triage point is day 7, where their employer can ask them to produce a GP fit note if they're still their work still is affecting their health. And this is what you all on the call will be familiar with, this idea that the fit note is very often signed off as not fit for work. In fact, more than 90% of the time it's signed off as not fit for work, making minimal use of the maybe fit for work section that the fit note was introduced to provide over 10 years ago. So that's the status quo currently. And then if they continue to not feel well enough to work, a fit note can continue to be renewed up until about 6 months' time. And just before that threshold, they can start thinking about moving on to longer term benefits. And at 6 months' time, their statutory sick pay ends and they move on to longer term benefits. Obviously, that's the kind of social safety net, and depending on where they work, there might be a complementary organisational offering, and that differs quite a lot depending on where somebody works. And obviously, that's not necessarily the focus of today, but it is important to think about. And I think both Lola and Louise have will be highlighting some of this later on. So it's worth just thinking about. So as Lola was saying, a manager conversation. So these are the variables in organisational policy, things that can actually have quite a big bearing on somebody's health and work journey, but they're quite variable. So manager conversation could be very productive early on, establishing what's going on and how the organisation can support that person through what to do next. Secondly, increasingly, organisations are offering healthcare through work, and that can help in terms of expediting treatment that they may otherwise be waiting a very long time for. Occupational health is another variable, and again, different organisations may or may not offer it, but whereabout they offer it in the journey is also important. And of course, there's the corporate sick pay timeline. So if somebody is on full pay and then they drop to half pay, those things will really affect their journey through health and work too. So just a quick thought on how we can leverage employer buy-in, and that's all about supporting employers to develop best practice. Some things to think about are supporting them navigate the provider landscape, which is very complicated, and particularly divert their investment to evidence-based interventions. And that's really difficult because the corporate wellbeing industry can be very confusing and not always evidence-based. and it's all about showing where incentives align and demonstrating return on investment. So before we move on to think about an ideal referral pathway, it's always useful to have a case in mind. So this is a case of Mr. K. He's 48 years old. He works in retail setting on the shop floor. He's had a heart attack recently, and that's left his heart functioning not so well. So he's finding it harder to do moderate exercise. Things like walking have become harder, walking and talking at the same time. He feels more fatigued at the end of the day. So what would an ideal referral pathway look like? So these are the things we're going to touch on: managing expectation, timely interventions, data gathering and using that data to inform a tiered approach, the importance of shared decision making, resource knowledge and feedback loops. So the first thing, managing expectations, this is to do with signposting and this idea that somebody may be fit for some work rather than not fit for any work at all. And that's been a very challenging part of general practice fit note consultations for a very long time. And I think partly that's due to the expectation and media dialogue. So this is a headline from probably a couple of weeks ago, and we're still talking primarily about sick notes. And that means when patients come in talking about health and work, that's their expectation, and it can be quite difficult to get them thinking about anything else. So for example, when Mr. K comes into practice, and we say, okay, I can see being on your feet all day on the shop floor, organising the product, speaking to customers, that's going to be tough. But what about something else you might be able to do at the workplace? He might say, look, there's no way I can work like this. I need a sick note. So he's in that very binary place, and trying to move him on in the next 10 minutes, which is the time we have, is going to be very challenging. Second thing to think about, timely intervention. So evidence tells us the earlier the intervention, the better. And that's because we know that once someone is off for 4 weeks, there's already a 20% chance they'll never return to work. And fit notes are the gateway currently. And a lot of the time, in fact, almost a third of the time, they're being signed off for 5 weeks or longer. So we're missing that window. So in order to optimize referral, earlier intervention would be better. Third thing to think about in terms of referral is data gathering to help inform our needs, which is basically a triage process. What kind of needs does an individual have on a health level? How is their function? Where does their psychosocial setup leave them? And we can use that data gathering to actually inform a tiered approach according to their needs. What kind of resources will help them here? So is there an issue of acute risk at the workplace? Would adaptations or sickness absence be appropriate? What's going on with their health? Could we optimize medically with therapies such as physiotherapy or psychological therapy? And what about their return to work element of their presentation? What kind of support do they need in that regard? So thinking about Mr. K, the gentleman in his 40s who's had a recent heart attack, he says, my job is really physical. Walking around the shop floor would be impossible in this state. So based on his function, it seems unlikely that going back to his full job at this point is going to be safe and sensible for him. So we're already thinking about the need for adaptation. Thinking about his health, though, where is he at with his health? Are we sure he's on the right secondary prevention following this heart attack? Has he seen cardio? Do they have any plans to help optimize him going forward? Has he been invited to cardiac rehab? And many people become low in their mood after a heart attack. Would he benefit from psychological therapy? So we need to establish how much leverage do we have here to optimize his health? That's going to really affect his return to work trajectory if things could get better from here. Finally, we need to think about the psychosocial return to work support. So in the case where we might establish that actually perhaps he could do a more sedentary job in his current workplace, such as being stationed on the tills for a bit rather than helping on the shop floor, he might say, you know, at my workplace, we've had this discussion before, people have to rotate jobs. They're not keen on people staying on tills. They want everyone to rotate roles so it's fair. So here we've got some information that actually he could do with some psychosocial return to work support to help get that communication across to his employer. Then we need to think about this element of shared decision making. So finding out a little bit more about his psychosocial context and what his push and pull factors are to help this work for him. So if we ask him about work, he says, I've always liked work. It gets me out of the house, but I've always had to help with my partner's care. And I think we're both going to be struggling a bit more now that my health isn't great either. So we've got a bit more information there about what else might be a barrier, the other push and pull factors that we then need to utilise in supporting his return to work. Which brings me on to thinking about comprehensive resource knowledge. So the first thing here is interagency collaboration. This gentleman could benefit from psychological support, physiotherapy, and medical support from cardio specialists. He may also benefit from GP input and resources such as a social prescriber or even a social services input, depending on what's going on with his partner's care. And that's in addition to the work and health support, that communication about what's going on with his employer to try and get him some good outcomes. And the more of this that is timely and place-based, the better. And that's what we've learned in the Embed study, that being based out of a GP practice where multidisciplinary professionals can have meetings on site regularly, where service users are attending surgeries, so all of their care is based out of the same place, can be really, really helpful. The final thing to consider here with an ideal referral pathway is the importance of a feedback and follow-up process. And the reason for that is really twofold. Firstly, the importance of individual follow-up. Can we make sure this individual is getting what they need? And secondly, where does this leave the process from a QI and systems learning perspective? So say we follow up with Mr. K in a few weeks' time, and he's been back to work with adaptations, and he says, I've got back to work thanks to the letter the work support officer gave me. That's been going well. And also I was on the waiting list for psychological support and that appointment has come through. However, my employer isn't sure about giving me time off during the working day to attend those appointments. So there's two elements of learning. Firstly, what can we sort out for this individual here? It would probably be useful to write to his employer and encourage them to consider giving him time off to attend some healthcare appointments as a reasonable adjustment, but also process learning. It may be useful for us to think about on the front end of cases like this, whether we need to be communicating with the employers that where follow-up is required, it may be useful to help them consider letting their employees get some time to attend those appointments with a view to improving their health and productivity overall. So these are the points we've spoken about: managing expectations, making sure people are primed for that dialogue about health and work, the importance of timely interventions, using data gathering to inform a tiered approach to support, keeping person-centered care at the core of shared decision-making, the importance of interagency collaboration, resource knowledge, and feedback loops for quality improvement and systems learning. So that's it from me. Over to you for any questions.
Lara, thanks so much. So much in there to think about. I think for me, both in terms of what a referral pathway might be looking like ahead of a work and health offer, but also informing the work and health assessment offer itself. There's so much in there that we can then draw from, and very helpful, I think, to see it through that lens of an individual case study, and just to really reinforce the importance of that interface with primary care across this whole agenda. So thank you. Let me open up wider for any questions for Lara. Becky, do come in.
Oh, thank you. I'm Becky Chapman. I work in the job centre in Norwich and look after sort of a health team of work coaches. So really interested in all this discussion. And I suppose my question, Lara, was around GPs and how much time they can give to this. As you were saying, there's a 10-minute appointment. Is that something that sort of is realistic for GPs to consider all of those things in that time? I know we find, if we do try and make connections with our local surgeries, which we do try and do here to support customers, and often it's good relationships, but there's a limit to what we can how we can work together, just because of their time pressures more than anything.
Yeah, what a brilliant question. So I think the 3 barriers to GPs delivering this content effectively within their own consultations are time, because of course someone might come in with a health issue and then this work conversation comes in as a second item in a 10-minute consult. So that's a real challenge. And the second is skill. So not all GPs have much occupational health training, and lots of other healthcare professionals may be more experienced depending on their training and what they've been up to in their careers than necessarily GPs in this. And the third is that point around managing expectations, and how it can feel so difficult to negotiate that in a short space of time. So in terms of moving forward from this, can GPs give time to projects that are delegating more of this away? In the Embed study, we have seen that yes, because they see better outcomes from their patients, and it is time saving in that those FitNote conversations are diverted elsewhere, or at least a lot of those, a large part of that dialogue is happening elsewhere. That's possible, and that's been working really well with Embed. And the other thing to think about is thinking about that data gathering and how much of this, and it would depend very much case to case, but what kind of support is needed for each case will be really variable. So there will be some people that have a high degree of medical complexity, a high degree of risk, and those individuals will definitely need some kind of senior clinical input. And there may be other people whose health has actually been pretty stable for a while, and they have more kind of psychosocial barriers to return to work. And in that case, you may not necessarily need to be a GP to be coordinating that. So quite a lot to think about in that question, but hopefully that covers some of the bases.
Yeah, it does. Thank you. I was thinking along the lines of social prescribing as well, and how all that fits into this, or is that essentially what you are describing there, as it were, the social prescribing model, and is it that kind of?
Yeah, so I think that's, I mean, in, clinical and non-clinical people working side by side works really well, and the social prescribing model demonstrates that. But in a case where you might have like a DWP work coach coordinating this, for example, taking Mr. K, he might need actually a GP to make sure he's got the cardio follow-up he needs and so on. But equally, perhaps getting a social prescriber to look at his situation as a carer may also, so it really is about collaboration and using the MDT to the best of everyone's ability to get people back.
Thank you.
Thanks.
Really helpful, thank you. David, would you like to come in next?
Yeah, hi, thanks for that. So I'm wondering, is there anywhere where you've come across where there's a particular pathway defined where the GP is asked only to sign off the FitNote for 7 days, for example, pending pending engagement with the work and health service? So something where they've got on an EMIS template where they can't sign off a month, anything like that, or would I need to speak to my own local primary care colleagues to try and work out whether that's possible?
So to date, I haven't come across anything where people are capping FitNotes very early on and trying to bring in work and health expertise early. What we're seeing with the Embed study is as awareness increases within practices, GPs are increasingly comfortable in bringing on work coach expertise earlier in the journey. So I think that begins to happen where they see someone, they say, right, here's a FitNote, and actually, are you willing to see this person? They may really be able to help. But I haven't seen any rigid pathways in that regard. Not that I have, obviously I'm not entirely sure of everything, but yeah, from my experience, that's what's going on.
Okay, I'll investigate with some local GPs and primary care colleagues to see what the likely response to that would be. The other thing I was going to say, which is more of an observation rather than the question, is with the threat of industrial action in general practice, the timing of getting GPs to engage in this type of what they would perceive as additional activity, because obviously the threat is that they will go into kind of a, almost a work to rule type environment. It's going to be complicated for us, I think. So it's just worth bearing that in mind on the national stage.
I completely agree, and I think that's why it's extremely important that this actually is time and outcome saving for GPs. So where they can see actually these things will quickly be diverted to somebody else, and there's not going to, you're so right, bandwidth is really, really limited in general practice. So it has to be extremely clear that this is going to be helping with workload and with outcomes.
Thank you. Yeah, I think the point that I would add to that is also considering whether there's the opportunity to add capacity into a primary care setting through funding streams like WorkWell. There isn't nothing to say that you couldn't use WorkWell investment in that way to actually, a bit akin to where we have a DWP work coach in a GP setting, sort of funding a role who actually is embedded within primary care, whose role is interfacing into that wider work and health offer. Could be interesting to consider. David, do come back in.
Well, yeah, it was on that very point, actually, thinking through what the operating model would be. We've got two different, quite distinct places in our patch, Herefordshire and Worcestershire. I know it sounds obvious from the name, but they are two geographically quite distinct places, both relatively rural communities. So coming up with a one-size-fits-all doesn't always work in the same way as it might in a more geographically compact ICS with different places. But in one of those places, we will very much be looking at the local GP federation, the general practice community taking a lead to try and develop the operational model to implement, and then engage the local voluntary sector to provide some of the support services. So it'll be that's one of our kind of thought processes that we've got at the moment. Anyway, more work to do, obviously, as part of the implementation plan.
Yeah, of course. And I think, just two sort of almost like points of principle, which are bit statements of the obvious, but very much WorkWell very much specifically funded with that sort of thing in mind. So with the flexibility to develop the service differently depending on the setup, the needs of, the characteristics of the local area in terms of population and wider. I guess I'm interested, Lara, just from the embed study, but elsewhere too. What do you see as good practice in terms of streamlining that interface between primary care and wider offers locally? You talk about the multidisciplinary team, which makes a lot of sense. Is there also a kind of system interface question that you've come across?
Yeah, so there is a complexity here in the kind of outward facing communications that go to employers, and that's something that's really, really difficult to navigate. And in the embed study, we are using a completely kind of sealed system, which I think has been pretty good. And obviously there's a lot of back and forth about what can go out and what can't, and it's so important from a service user confidentiality perspective to keep that top of mind. So I think where things have been working well, it's been to do with the relationship confluence as people get to know each other, work coaches get to know their GPs, patients attend the same site for this kind of care, and they talk about kind of the work coaches start getting more referrals as they get to know the teams better and seeing the outcomes. So I think that in that regard, like that place-based thing works quite well.
Alex, there's a question on the Q&A. I don't know if you've seen from Anne Burgess. Have you seen that?
Thanks, Nick. No, I hadn't seen that. Let me just try and open. Would you mind coming in with the question, Nick, just while I open up the Q&A tab?
Yeah, sure. Unless Anne Burgess wants to do it. She's saying which each of these steps in the pathway, who or which roles do you see undertaking having these conversations? We have a patient advisory service set up in a PCN with a DWP advisor and trying to refine the SOP as we've experienced some challenges in GPs remembering within the consultation time?
Yeah, so I think the essence of that question was around who is best placed to triage. Is that about right? And I think that's a complex one because training is effective at helping people pick up when complexity requires clinical input. So I think in the presence of good training, we have shown through Embed that non-clinical people know when to get OH expertise in and know when to feed back to GPs and that sort of thing. So I think that can work where training is high quality.
That's great, thank you, Lara. And just referring back to our last in this series of webinars, we talked about that work and health training offer and what makes a good work and health conversation, which Professor Kim Burton talked about. So do have a look back at that recording, anyone who hasn't seen it, and we'll be sharing more materials on that training offer in time as well. Right, I think I should move us on. That was a really rich conversation. Thanks ever so much, Lara. Let me turn to our final presentation today and bring in Louise, who's going to talk to us a bit more about working with employers to help them improve their offer. Thank you, Louise.
Thank you. Delighted to be here. I'm Louise Zaston, and I'm a mental health and wellbeing campaigner consultant. And until very recently, I was wellbeing campaign director at Business in the Community. So the perspective that I'm going to be sharing with you is basically from an employer point of view, working with employers to help them improve their offer. And this is basically everything in this presentation and the resources I'm going to share with you. Just to stress, they're all freely available and they've all been designed to be useful and appropriate for any organisation, regardless of size, sector, public or private. So next, please. So this is a quick overview of what I'm going to be talking about. So why employers need to improve their offer. The opportunity they've got for unlocking the kind of true value of a thriving workforce. Also in terms of actually an evidence-based approach to understanding their starting point and embarking on a journey of progression and thinking about adopting a new wellbeing partnership between employer and employees. Next, please. So why do employers need to improve their offer? Well, we know that basically less than 10% of employees in this country are engaged or enthusiastic about their work, and we're pretty low in terms of engagement scores in European countries. We also know that basically candidates are way more interested now in work life, whatever you want to call it, balance, and that's actually more important to them, to many of them, than the salary. And then, you know, this is a worrying figure that over half of employers recall a lack of enthusiasm about their job, being under excessive pressure and exhaustion, and obviously that's linked to burnout as well. We know we've got a kind of burnout crisis going on, and particularly concerning with younger employees. And people's kind of values are changing. Is that, you know, over half of candidates wouldn't even accept a job if they didn't know or agree with the company's purpose. So this alignment with an organization's purpose and values is becoming increasingly important. Next, please. So I think it's fair to say that traditional models of working aren't really working. And we've seen that, you know, a lot of the previous speakers have kind of touched on is poor mental health, you know, high rates of burnout. We know that we've got worrying high attrition and low productivity. So essentially, employers have got two choices: do nothing, which isn't sustainable and will risk that employer going out of business, or actually redefining success by prioritizing people to unlock the value of a thriving workforce. Next, please. So last year, we at Business in the Community, we worked in partnership with McKinsey Health Institute. That's the not-for-profit arm of McKinsey. And for the very first time, is rather than looking at the cost of absence, just absence, and kind of sick leave, we actually turned things on their head and actually looked at the massive opportunity in terms of supporting thriving people, which in turn kind of supports thriving businesses. And it's also the right thing to do from a corporate social responsibility point of view. So in that report, and you'll see there's a link down there, there's a really compelling business case for business leaders to prioritize employers to be, you know, truly at the heart of their organizational purpose and business strategy. And I don't think that's really true with many corporates, organizations. Is, you know, well-being is still a bit fluffy, it's still a bit of an add-on. And I mean, the size of the prize for getting this right is basically, in terms of maximizing the well-being of employees, you know, that could be up to 17% additional UK GDP. And when you translate that to numbers of employees in individual organizations, you know, that ranges from 4 to 12k per UK per annum. So even if you just got 20% in the right direction, you know, the size of the prize is absolutely massive. But the other huge thing that this report highlights is that actually no interventions or well-being strategy is actually going to be effective if you don't tackle negative workplace culture. Next, please. Oh.
Sorry, Nick, we seem to have lost the slides.
Okay. So what makes the negative culture is a negative culture is characterized by negative behaviors, attitudes and practices that can harm the well-being of employees and create a negative impact on organizational success. So key elements could include poor leadership. So that's ineffective or negative leadership that fails to inspire trust, communicate effectively, or indeed lead by example. Bullying and harassment, again, you know, bullying, microaggressions, harassment, or discrimination can also create a hostile and unsafe workplace. Lack of transparency, a lack of openness and transparency in communication, leading to confusion and distrust among employees, and high rates of employee turnover, which indicates dissatisfaction and potential issues within the workplace. So in terms of supporting thriving people and thriving business, I think it's apt that when I worked at Business in the Community, we actually developed a biopsychosocial model that is called the Workwell model. Again, it's completely freely accessible, and it kind of takes a three-pronged approach in terms of prevention, early intervention, and active rehabilitation. And in terms of all the kind of elements that go into creating culture, is at the center there is leadership, and then a lot has been talked about, you know, good work actually is enhancing for well-being. So in terms of good job design, better management, better specialist support, and better health and well-being, which takes a very kind of holistic approach to health and well-being in terms of physical, mental, social, financial, spiritual. Again, wrapped around the whole model is an inclusive culture and collaboration with stakeholders. So at the end of last year, we launched, it's really innovative. It's something called the BITC Workwell Self-Assessment Tool, and it uses the Workwell model as a kind of template. It's freely available. It's designed to be useful whether you're an SME or a large corporate. And basically, it's online. There are 21 multiple choice questions in total, aligned to the 7 elements of the Workwell model. It's completely confidential, but basically it's a really useful tool in terms of actually being able to understand your starting point and embark on a journey of improvement and measure and report on your progress. There's also the opportunity to compare, again, confidentially, your score against a national benchmark. So you can track your progress and actually see how you compare with other sectors. So basically, in terms of that tool, the Workwell self-assessment tool, it's really good about assessing your kind of starting point. But ultimately, you know, culture is about people. And in terms of a new kind of partnership between employers and employees is crucial.
Louise, I've lost you. Are other people struggling to hear Louise as well?
Yeah,
Yes.
I've lost her as well.
Yes.
Louise, if you can hear us, I don't know whether you're able to come back in. I'll just give Louise a couple of minutes to try to rejoin us, and perhaps otherwise we'll open up for slightly wider conversation.
Yeah, it's just coming back in right. So.
Hi, Louise, are you back with us? Hi, Louise, I think we've got you back.
Sorry?
I think we lost you there for a few minutes, but you're back, I think.
Brilliant.
We can hear you, yes. So you were just talking us through the assessment tool, and Nick, if you'd be happy to put the slides back up. Louise, do carry on.
Okay, thank you very much.
Thank you.
So this is the Workwell self-assessment tool, and I really urge you to check it out. So you can see the link down the bottom. But it really is a simple and easy way to see where you're going, what kind of baseline is. Next, please. So I've talked briefly about the new partnership approach, and we know that culture is about relationships between people, which is why this is about resetting a relationship between employers and employees. So that's about sharing the responsibility for well-being beyond traditional roles, allowing for both employers and employees to benefit from healthier rights while holding each other to account. So there's a real echo. Can you hear that?
We can't. If anyone's not on mute, if you could mute that would be helpful. But Louise, I can't hear the echo.
Okay, that's good.
Yeah.
So basically,
Yeah.
in terms of this shared responsibility, this is all about employers creating a supportive environment where employees have psychological safety, one where employees can thrive and encourage ways of working that promote health and well-being. So this is back to work well in terms of it being enhancing for health and well-being. And then for employers, it's about taking personal responsibility for bringing their best selves to work by taking care of their health and well-being, staying positive and contributing to a positive workplace culture. Next, please. So in terms of employer responsibilities, this is about employer committing to creating a supportive environment and ways of working that actively promote health and well-being. So that's about prioritizing well-being as kind of being at the heart of organizational purpose, values and business strategy, really promoting and delivering equality, diversity and inclusion, where everybody feels psychologically safe and a sense of belonging. And then fostering a positive workplace culture that encourages collaboration, open communication and mutual respect. We know that workload management is really key to preventing burnout and ensuring that employers have a reasonable and manageable amount of work. Role of effective communication, professional development opportunities, and of course, fair compensation and benefits. Next, please. So obviously this is a symbiotic relationship. So individuals need to take personal responsibility for bringing their best selves to work by committing to certain behaviours. So these are complementary actions that employees commit to. So taking care of their own physical and mental health by prioritising self-care, managing stress and seeking support when needed, contributing to a positive culture, building relationships, maintaining a positive attitude, open communication, and owning mistakes and learn from them. So that's about psychological safety as well. So when both employers and employers actively fulfill their responsibilities, you know, this mutually beneficial relationship can be formed, which maximizes employee well-being, but also enhancing business success. Next, please. So there's obviously benefits of establishing this relationship in terms of employer benefits, employee benefits, and mutual benefits. And you can see, you know, this is really attractive in terms of benefits for both parties, but also mutual benefits, which again, in terms of actually creating a thriving and sustainable environment for long-term success, and indeed being an employer of a choice, making work attractive. There are numerous benefits. Next, please. So here's a summary of what we've about is the compelling business case is to take a look at prioritize people, unlock the value of the thriving workplace, take a look at the work well model and the work well self-assessment tool. And in terms of this new concept of this symbiotic well-being partnership between employers and employees. So happy to answer questions.
Thanks, Louise. Tons of information and advice in there for employers and the role they play here, and lots of support in the chat as well for that equal emphasis on employers as well to play their part here, and the kind of the scale of the opportunity for employers to benefit if they do. Let me bring in Steve for the first question.
So, yeah, there we are. Thanks very much, Louise. Yes, as everyone else is saying, it's really valuable. The point I just wanted to maybe explore a bit more was about the interface between the employer and the employee, which is the line manager. So a lot of employers might have very good intentions at senior levels, but maybe that hasn't quite filtered through to the direct line management. And if that relationship doesn't work well, then it pardon the pun, but if that relationship isn't effective, then it doesn't matter what the senior management's views are. There's going to be difficulty. So the question is, how can we make that relationship as effective as possible?
I think the organisations that are doing this really well is where actually line managers are actually judged by the well-being of the people they manage. Is if well-being is genuinely integrated to workplace culture, is actually line managers don't really have a choice. And you know what? You can learn empathy. So in terms of active listening skills, and in terms of how you're judged and how it aligns with the values of your organisation, I do think there's a lot of leverage there.
Yeah, that's great. Thanks very much.
Thanks, Louise. And thank you very much, Steve, for that question. Becky, let me bring you in.
Hello, thank you. Thanks, Louise. That was really, really interesting. It wasn't quite so much a question, it's more just to wave a flag for something. I was thinking throughout the whole thing, disability confident, the scheme, the DWP role the government runs, which I sort of advocate for in our region. It's all of those things that you were describing. It's promoting those work environments that are better for all of us, regardless of whether we've got long-term health condition or disability. And you know, we wake up tomorrow with something, can't we? So it's for all of us, and I think it's so important, and it's really always really heartening to hear from employers that are thinking about it. I find that particularly with disability confident people who sign up to, or employers who sign up to that scheme, have really thought about it and are really prepared to put in that time and effort to improve the whole time, because it's never you never get to the end, do you? It's kind of, there's always room for improvement and change as the business changes or the environment changes. So yeah, I found it really interesting. Thank you. And if there are any employers on here who aren't disability confident, I think it's something worth checking out. So I'll put the link in the chat if that's all right.
Yeah, no, it's a fantastic scheme. I've always been really impressed what DWP are doing on that. And, you know, with the work well model, you'll see the outer ring. Actually, the whole model is kind of encased by inclusion. And as we know, ED&I is high up on every corporate kind of agenda.
Yeah, excellent, excellent point to raise, Becky. Thank you. Good to always have disability and confident in mind in this kind of conversation. I had a question, Louise, I suppose following up a little bit on Steve's point about line managers. Lots of people on this call who will be representing organisations who are delivering work and health services around employers that can be a helpful offer to employees, and might include some sort of employer interface, like offering employer engagement on behalf of the individual. I just wondered if you have any reflections on, perhaps at a more individual level, what does good practice look like in terms of how that information is presented to the employer, what's useful to the employer, in what format? What have you seen works well?
What we've seen has been incredibly powerful is with the prioritize people, unlock the value of thriving people, is actually use that research to have an executive board conversation, ideally involve your finance director, because in terms of actually getting that buy-in and this amazing size of the prize is actually that some way of influencing policies where well-being is genuinely embedded into organizational purpose and is reflected in policies, values, and how people are judged and they behave.
Thank you. Well, that's a really powerful note to just conclude that part of the conversation on just yeah, that enormous size of the prize and how putting people at the centre can help employers capture that. Let me welcome Lola and Lara back into the conversation. We'll just open up for any final questions for the panel. And I'd also just like to come to each of you, if possible, to really just summarise for everyone, so everyone's got the key takeaways front of mind when we leave. What your personal kind of top takeaway would be from this conversation, what you would like people to keep in mind as they carry on with their Monday afternoons. Shall I, can I turn to Lola first to reflect on that, and then please, everybody, do feel free to put any final Q&A in the sidebar as well. Thanks, Lola.
Thanks, Alex. So I think my first takeaway is that workplaces provide a great opportunity to create health and also prevent a whole range of preventable conditions by creating that healthy environment and supportive environment for their employees. But the second thing is, if we really want to understand the work and health needs of a local area, it's a team sport. You need to go out and find, you know, those key stakeholders, bring them together, bring the data and insights that you have collectively to create that picture of what is happening in your local place, to identify the right priorities where you can make a difference and take action. And there's a lot of resource out there to help you in in focusing on what actually makes a difference in practice.
Fantastic, thank you. Lara, can I come to you next?
Sounds good. Yeah, I think for me, it's going to be, if you're thinking about referral pathways, think about time, place, and interagency collaboration.
Fantastic, and I can see a theme emerging here around that collaboration point already, which is one which runs through this this whole agenda. Louise, I'm going to come to you finally, just for your key takeaway, and also let me just mention that Susan in the sidebar has talked about CIBPD having a publication for line managers on this type of topic. That sounds likely. Thanks, Susan, for flagging it, and feel free to share any links that you've got, Susan, as well. So anything on that, Louise, and then your key takeaway, please.
I'm just going to cover the takeaways. So I think if you want to prevent people from falling out of the workplace, you need to think about tackling a negative or toxic culture. And because there's no point introducing wellbeing interventions and the strategy if you haven't actually tackled that toxic, negative culture. The importance of taking a systematic biopsychosocial approach, and think about using the work well model, which obviously is aligned perfectly with what you're doing. And finally is think about adopting a new kind of well-being deal in terms of a symbiotic partnership between employer and employee, where both have responsibilities.
Thank you, Louise. Just trying to get off mute there. That's been fantastic. I think we've had a number of themes come through today, and I hope that has really reinforced for everyone the critical role that that workplaces can play in this agenda. That the opportunity for that symbiotic relationship between employers and employees, and the huge scale of the prize on both sides of the coin, yeah, that collaboration at the heart, Lara, also of those referral pathways, and that interface with primary care particularly. I hope that's come through really strongly for everybody. Let me just close by saying a huge thank you again to Lola, to Lara, and to Louise. What a tongue twister of panel names. Your contributions have been incredibly valuable. We really appreciate it. I hope everybody found these seminars, not just today, but our previous 2 seminars as well, to have been useful. We want to share the resources as widely as possible, so we will be sharing the slides after today, which have got incredibly helpful links within them as well. And we have been recording today, so do please feel free to share on this recording wider to your colleagues, just to we're keen that this information is shared as far and wide as possible. Thank you again to SOM as well for your support in bringing these together. And yeah, just one final time to the panel for taking the time to come and speak to us all today. I will close us there. Thank you very much, everybody. Enjoy the rest of your afternoon.